This is part 3 of the bioequipment talk. In this last section, we'll discuss tables and patient positioning. A common question you'll be constantly asked as a surgeon is, what type of bed do you want? The type of operating bed depends on 3 factors. First, the patient's weight and height. Second, your fluoroscopy requirements. And third is the procedure requirements. Most operating room tables are limited to less than 500 pounds weight and 7 feet in height. Otherwise, you may need an extension or an alternative bed. Be sure to know the weight and height limits of the bed you are using. This is especially important for older tables. Older tables have lower limits of about 300 pounds weight and 1 meter 90 to 2 meters height. This would mean that approximately 25% of the patient population would not be appropriate for an old standard operating room table. Alternatively, there are tables that can carry up to 1,200 pounds or 500 kilos, but thereafter, veterinary tables may be required, or you can also strap 2 beds together to accommodate the patient. Even though a table may be radiopaque, the table margins may still be made of steel, and the table may have a central stem or post that may be in the way if any angle shots are needed. This is very important for pelvic imaging. Try to obtain pre-incision images to ensure adequate access and visualization, not only due to the table, but also from padding and positioning instruments. The last factor to consider is the procedure itself. Certain tables are necessary for certain procedures. Hip arthroscopy, lateral spine procedures, and certain types of fractures are all more easily and safely performed with specific bed positioning. While certain beds can only provide static positioning, some can also provide dynamic positioning, which can be both beneficial and necessary for certain types of procedures. A special bit of note is the Jackson spine table. Originally developed for spinal fracture patients, it allows the patient to be sandwiched between 2 plates and then rotated, all the while keeping them in a specific spinal alignment. More importantly, the bed has no central post or stem. This allows for great pelvic imaging, especially during acetabular and pelvic fractures. Although the various tables allow for a wide range of positions, there are both benefits and risks that arise from each of those. For example, in Trendelenburg position, this allows for reduced pressure for dural tears, but it carries the risk of cardiovascular risks. Prone positioning also has increased risk for both eye and genital injuries. Likewise, beach chair positioning has reduced blood loss when operating on the shoulder or upper limb, but at the same time, there's increased cardiovascular risks. So what are the most important factors to consider when positioning a patient? In this example, the patient has ankylosing spondylitis, and you will not be able to obtain a regular positioning of the patient. Start with pre-op screening for any fixed flexion deformities or spinal deformities. Be sure to place padding under all bony prominences, especially during longer procedures that last over 4 hours. Try to avoid applying adhesive tape directly onto the skin for strapping a patient in. Remember that the most common nerve injury is the ulnar nerve, which makes up approximately 35% of all cases. This is followed by the brachial plexus. The common perineal nerve is the most commonly injured lower limb nerve, and usually due to the use of stirrups around the fibular head. So even when placing patients in a supine position, try to avoid stirrups around bony prominences like the fibular head, and be sure to pad bony landmarks like the elbows, wrists, and ankles. In regards to prone positioning, be sure to pad all bony pressure sites and keep the belly free from any pressure on the abdominal viscera. Also remember to pad the kneecaps and iliac crests. The shoulders and elbows should always be kept less than 90 degrees flexion or abduction. And ideally the patient should be screened preoperatively, because the worst situation is to flip someone over and then to realize that you cannot position them safely due to a fixed flexion deformity. For example, if their shoulder does not extend or does not abduct greater than 60 degrees, then you will be very limited in terms of their patient positioning. Also, once you have positioned them in the prone position, remember that the thumbs should always face forward or inward. Also, always check that joints like the ankles are not excessively dorsiflexed, and perform a final check of the genitals and nipple regions on all patients. Although the exact pathophysiology of postoperative vision loss, or POVL, is still not understood, try to avoid placing the patient in a prone position with Trendelenburg inclination. This may increase pressure on the retina. A special bit of note is the Jackson table, which we had mentioned. One of the other advantages is that it allows for rotation as well as clearance of the belly. Although this is not a feature of the table itself, but it is important to note that all prone positions should have their bellies free. This not only avoids injury to the abdominal viscera, but also minimizes vascular pressure. This is especially important around the spinal veins, because those veins are valveless, also known as Batson's or Bateson's plexus. Therefore, if abdominal venous pooling is restricted due to pressure on the abdomen, then the blood will pool into the spinous plexus, and making surgical dissection around the spine all the more challenging. So, in summary of our bioequipment talk, remember that wound closure is necessary during the inflammatory phase until the early proliferative phase within the first 5 to 7 days. Liquid and TEEP adhesives are equal in terms of their outcomes, except that liquid adhesives are waterproof. In terms of suture selection, remember the 5 most important factors are their coating, their absorption, the type of needle you want to use, the strength, and the stranding. Remember, the size is not important. For negative pressure wound therapy, remember that this increases perfusion to the site, and that minus 75 millimeters mercury should be used for high-risk patients, but otherwise minus 125 millimeters mercury should be used. Try to place the setting on for continuous for the first 48 hours and then intermittent. Remember that it is contraindicated in osteomyelitis, cancers, coagulopathies, and exposed vessels or tendons. They can be used in some circumstances when you change the type of foam being employed. The white foam is only about 100 micron thick in terms of its pores compared to the black foam, which is 500 microns. Therefore, the white foam allows for more moisture retention. In terms of electrocautery settings, this depends on the type of tissue that you are dealing with. For a cut, place it on blend to control bleeding. Remember that pure has no benefit, and generally all electrosurgery settings are placed on a blended cut setting. In terms of coagulation, remember that coagulation settings are only on approximately 5% of the time, and they can only be used for vessels which are less than 7 millimeters wide. Always be aware of the complications of electrosurgery, including coupling, conduction, and capacitative complications. Always check the padding. This is the #1 source of complications, and look out for any hair, moisture, scars, tattoos, and implants. In regards to tourniquet use, S-marks should only be used for hand and foot surgery. Otherwise, they should be removed once the exsanguination is complete. The settings for a pneumatic tourniquet depends on the patient's age and their systolic blood pressure, but should never exceed more than 250 millimeters mercury for the upper limb or 300 millimeters mercury for the lower limb. There is controversial benefit of using a tourniquet, and several studies have not been able to show any significant difference. Always remember to deflate and provide medications prior to inflating the tourniquet, and always deflate the tourniquet prior to reaming. Avoid the use of tourniquets in cardiovascular patients, those with infections, sickle cell patients, and limbs with fistulas or vascular surgery. In terms of complications, neuropraxia is the most common complication. but also be aware of post-tourniquet syndrome, which can be either acute or chronic. In terms of operative table positioning, know the limits of the operating table that you are using. Remember that older tables, prior to the 1980s, accommodated less than 300 pounds weight and approximately 6'7" height. Be aware that there are surgical benefits of using different tables, and always be sure to flex joints appropriately and check padding and all bony prominences, including genitalia. Minimize nerve risks by applying padding, and be aware of the ulnar nerve followed by the brachial plexus and common perineal nerve, which are the most commonly injured nerves. Thank you.